Hello, Nursing 512 colleagues. The following presentation is on barcoding in the emergency department. Medication administration errors have been reported to range from 2.4% to as high as 49%. Medication administration errors can lead to patient harm or even death, and nurses play a key role in the medication administration process. Barcoded medication administration has been reported to reduce medication administration errors by 40 to 70% in hospitalized patients. However, there is limited use of barcoded medication administration in the emergency department due to limited deployment of information systems. Emergency department nurses should have resources at their disposal to eradicate medication administration errors. Hence, the PICO question. In patients presenting to the emergency department, does the implementation of barcoded medication administration as compared to manual verification of the 5 rights reduce medication administration errors? A little bit about the search strategy. Preliminary search engines included Google and Yahoo to gather preliminary information. Search databases include the Cochrane Database of Systematic Reviews, EBSCO-CNOW, Ovid Medline, and Google Scholar. Searches were conducted with and without date parameters and with Boolean operators. Keyword and search headings were derived from the PICO question. Consequently, the literature review revealed a limited number of studies and a lack of research on the effects of barcoded medication administration in the emergency department. The Bunkowski study was performed at an academic tertiary care medical center emergency department at University Hospital on the main campus of Ohio State University. This was the first of 3 studies that had been looked at. University Hospital's emergency department is a 70-bed unit designated as a level 1 trauma center and has an annual census of 75,000 patients. The barcoded medication administration, or BCMA, was implemented on October 15, 2011. The design entailed a before and after study of medication administration errors around the implementation of barcoded medication administration. A total of almost 2,000 medication administrations were observed. Half were pre-BCMA and the other post-BCMA. The purpose of the study was to measure the medication error rate before and after implementing barcoded medication administration. Hence, the first study. Second study, the Henneman study, was conducted in a simulated emergency department environment at Tufts University School of Medicine. The prospective observational study of emergency department nurses administering a medication to a patient, an actor, in a simulated setting was published in December 2012. 25 urban emergency department nurses participated in 50 patient scenarios, 2 scenarios per nurse. The purpose of the study was to evaluate the impact of a barcode electronic medication administration system on the incidence of a subset of medication errors committed by nurses during the medication administration process in a clinical simulation setting. The third study, the Siebert study, was conducted at St. Joseph's Candler Health System in Savannah, Georgia. St. Joseph's Candler Health System is a 2 tertiary care community hospital totaling 644 beds with an annual patient volume of almost 23,000. Barcoded medication administration and electronic medication administration records were implemented during the fall of 2007. A pre-test, post-test, non-equivalent comparison group was used to investigate the effect of barcoded medication administration, electronic medication administration records on the medication administration accuracy rates at the two community-based hospitals. Now, the patient care units include med-surg units, telemetry units, rehab units, an ICU, an oncology unit, and an emergency department. The purpose of the study was to evaluate the effects of BCMA EMR system on the rate of medication administration errors in both regular and special care units, and analyze the differences in event rates from voluntary reporting, interventions caught by BCMA technology, and interventions identified through direct observation. The three studies do not necessarily rank high on the hierarchy of evidence pyramid. The Bunkowski study may have been impacted by the Hawthorne effect, whereby the results are affected by the bias of changed behavior of the subjects as a result of being observed. The Henneman study is limited due to the study being performed in a clinical setting without any of the usual stressors found in the clinical practice. The Siebert study did not take into consideration the prescribing of wrong medications. The Johns Hopkins Nursing Evidence-Based Practice process was used to determine the strength and quality of the research studies. The Bunkowski study and the Siebert study rate a level 3 in strength, as these are quasi-experimental research studies. The Henneman study rates a level 4 in strength, as it studied a group of nurses over time related to BCMA EMAS. However, the quality rating of the research evidence for all three studies is good, as the studies produced fairly definitive results. As identified by Bunkowski, barcoded medication administration was associated with a reduction in medication administration error rate to 1.2%, a relative rate reduction of 80.7%. Wrong dose errors decreased by 90.4%, and medication administrations with no physician orders decreased by 72.4%. As identified by Henneman, 84% of nurses determined that the medication dose was incorrect for patient 2 before starting the medication and did not give the medication. As identified by Siebert, with the implementation of BCMA EMR in the emergency department, the accuracy rate increased from 86% to 95%. When wrong time errors were excluded, the accuracy rate improved from 87% to 99%. The number of wrong dose errors decreased from 8 to 0. The results for all three research studies demonstrate that barcoded medication administration reduces medication administration errors. Recommendations for practice based on this evidence: further human and technological improvements are needed to ensure that the right patient receives the right medication. 2, health systems contemplating barcode-assisted medication administration implementation should consider deploying this technology to the emergency department. An implementation plan. This implementation plan is only the tip of the iceberg. The key stakeholders and our resource personnel include hospital administrators, accounting and finance, purchasing, information management, quality control, risk management, training, help desk staff, physicians, mid-level practitioners, pharmacists, and nurses. There must be a connection to a hospital information system and a pharmacy information system for BCMA to be effective. A computerized prescriber or order entry, the integration of BCMA into a clinical decision support system to assist providers with the appropriate prescribing of medications, and automated drug dispensing cabinets is highly recommended. The implementation of BCMA requires a wireless network or may require an upgrade to an existing wireless network and additional hardware. Educators and training will play a critical role in this implementation, as well as triage nurses and medication reconciliation technicians to ensure the accuracy of patient medication histories. Nurses should have options available for verbal and protocol orders for life-saving medications or for medications that must be administered by the provider, respiratory therapist, or other healthcare professional. Regarding the evaluation of the implementation, data should be collected and analyzed from the hospital information system regarding the use and compliance of barcoded medication administration. Utilization reports should be generated to identify trends and assist users who may be challenged with the new technology. Barcode overrides and wrong medication alerts should be tracked. Medication utilization, medication frequency and routes, and the number of medications administered in each occurrence should also be tracked. All data must be audited, and nurses should be interviewed to validate the data. In conclusion, medication administration errors are abundant, and some result in patient harm or death. Barcoded medication administration is not commonly used in the emergency department due to the limited deployment of information systems. However, the evidence supports barcoded medication administration as a viable technological resource to reduce medication errors and associated medication adverse events. Barcoded medication administration has the potential to assist nurses in the recovery of medication errors. Yet, the implementation of barcoded medication administration is a daunting task filled with complexity and requiring substantial capital and numerous resources. In closing, if you have any questions, please contact me directly via email or via the discussion forum. Have a wonderful evening, and thank you for listening.